That's
Okay.
fine with me.
All right. Thank you everybody for joining today's call. I'm so excited. Today we have two special people coming to talk to us right now. We have Amanda Elmore and Marina Bolser. I'm so sorry.
No, it's all good. It's all good.
And they're gonna come talk to us about the lifetime psilocybin use and opioid use disorder among pregnant and non-pregnant women and reproductive age in the United States. That's the title of the study. And yeah, they're gonna give more details about themselves now. So yeah, go ahead and introduce yourselves.
I am Dr. Amanda Elmore. I'm an assistant professor at the University of South Florida in maternal and child health in the College of Public Health. Um, my education began at the University of Kentucky in medical lab sciences. So I started on the clinical side of health, working in a hospital lab setting, doing like chemistry and hematology, urinalysis, all the labs that you get done when you go to the doctor's office or the hospital. And then went on to do my master's of public health from Florida State. Worked for a few years for the Florida Department of Health in their birth defects registry during the Zika outbreak. So we ended up conducting surveillance on over 500 moms and babies that had exposure to Zika during pregnancy, and looked at their birth defects and other developmental abnormalities among the children. And then decided to go back for my PhD in epidemiology from the University of South Carolina, and now have been at USF as an assistant professor for about 2 years. And I have the pleasure of co-presenting today with one of my previous students, Marina. So I'll let you introduce yourself.
Hi, everyone. My name is Marina. I have a bachelor's in health education from UF, and go Leaders. And I just graduated with my MPH in epidemiology from the University of South Florida, which is how I met Dr. Elmore. Um, my research focuses on substance use disorders and mental health and psychedelics as well. Um, and my background is also in mental health, geriatrics, COVID-19 contact tracing. I've worked for several nonprofits over the years in a psychiatric hospital as well as a health educator. And yeah, that's me.
Thank you for
Awesome.
that. That's wonderful.
So broadly, we're going to talk about psychedelics and maternal and child health today. So we'll talk about first some background on psychedelics and women's health. And then we'll go over 3 studies. The first one, Marina will present on psychedelic use and substance use disorders. And then I will talk about a maternal psilocybin survey that I have currently still open, but we've started to analyze that data. And then lastly, I'll mention a psilocybin and postpartum depression trial that is happening here at USF and some follow-up studies that we plan to do. So I do have some background slides, mostly just to make sure this is comprehensive. But I'm guessing you all know that what psychedelics are. So they're a class of psychoactive substances that induce altered states of consciousness by profound changes in perceptions, thoughts, patterns, and emotions. And I think one fun argument right now is between hallucinogen versus psychedelic. And to me, I think people are moving away from hallucinogen because people are microdosing or taking small amounts of psychedelics that are not necessarily causing hallucinogenic effects. And so I think most would agree that using psychedelic is a broader term to encompass any hallucinogen or psychedelic use. So the main types, so LSD, I'm not going to read these for you because I think you know what they are. Psilocybin mushrooms, which we'll talk about today, DMT, mescaline, which comes from the cacti, peyote cactus, ketamine, which is now widely used on the market for major depressive disorder and other conditions. So I'm sure you're aware that there's ketamine clinics popping up all over the place. I will say that this is a huge area of under-researched substance, prescription drug, whatever you want to call ketamine use right now. We don't have any data on long-term health outcomes of ketamine, even short-term health outcomes. And So that's definitely an area of research that I suggest for people who like that. And then MDMA, which sort of falls into psychedelics. Some people would argue that it doesn't. Some people would argue it does. And then PCP, which many think might have some long-term, some of the highest risk long-term for tolerance, dependence, long-term cognitive impairments. So as far as the history of psychedelics, of course, they have a long ancient history, were used for religion and spiritual and healing purposes. And then around the 50s, 60s, psychedelics gained attention in the US through psychiatric research and the cultural movements. And the early clinical trials for therapy of psychedelics were on end-of-life care. So that sort of end-of-life crisis, anxiety, helping treat that. And then treatment for substance use disorders. Of course, in 1970, President Nixon signed the Controlled Substance Act and changed psilocybin and LSD to Schedule I drugs and halted all research and pushed all use underground. So now here we are 50 years later, and things are starting to come back. Although, if you follow what's happening in terms of policy and psychedelics, it's an ongoing battle in every state. And for any research university. So research on psychedelics today, the FDA issued their first draft on guidance for clinical trials in 2023. And we're seeing more and more findings that psychedelics can help improve mental health. One of the main areas that are really being funded and also have support from people like Congress would be for treatment of PTSD. Actually, the governor of Texas is one of the major supporters of psychedelic research for PTSD, and has been pushing in Congress for that to be approved for a while. Just one example of some results, that 71% of participants who underwent MDMA-assisted therapy no longer met diagnostic criteria for PTSD at the end of the study versus 46% who received the placebo. Of course, this year in August, the FDA pushed back on approving MDMA for PTSD, and so that is an ongoing battle of what will happen. And the importance of rigorous, thorough, highly documented clinical trials done in the most ethical way possible, because without that, this is never going to become mainstream research. So there's ongoing trials for psychedelic therapy for substance use disorders. This is a major area of research for myself, and really what brought me into the psychedelic and maternal and child health research area. Most of my research is on opioid use disorder, really is polysubstance use disorder among pregnant people and moms, and treatment and access to treatment is just not great for any of those. And they also come with their own risks. So to me, if we can have psychedelic therapy that a mom could undergo, not during pregnancy, ideally before or after, where she has 1 or 2 doses of psilocybin and no longer needs to be treated for opioid use disorder. To me, that's a much better outcome and treatment standard than putting somebody on methadone for 10 years. So that's what led me to this. Then there's trials, major depressive disorder, PTSD. Those are 2 big ones that have the most research behind them. Postpartum depression, I mentioned there's a trial that's beginning at USF, eating disorders, and late-stage cancer mental health. So sort of where this research began with end-of-life crisis. So we were having a discussion about epidemiology at the beginning of this. I'm an epidemiologist, Marina is too. And so that means that we look at things on a population level. And so the first step of an epi is sort of describing what is the prevalence or how many people are using psychedelics at a population level, because that helps you determine what's the burden of the population or what's the importance of the research. So anytime you're asking for grant funding for a proposal, that's going to be your first or second sentence to say, this is how many people are affected by this. So about 13% of females 12 and older have used psychedelics, 2% within the last year. The risk for addiction depends on the type, but it's generally lower than other substances, as we know. We currently have no data on the prevalence of psychedelic use among pregnant people. The other important part of spelling out what's happening in the population is showing gaps in research like that.
Do you mind if I interrupt for a second and ask a question, or are you
No,
doing that?
yeah, no, go ahead.
So in the prevalence section, 12 and older, do you segment? Because I can just imagine in the population in general, 12-year-olds aren't doing much psychedelics. So like, do you see from 12, like each population from 12 to 13, teenagers maybe, young adults, how that's separated of the use of psychedelics?
Yeah, so all of my slides have the links at the bottom for where I'm getting these numbers, and I'm happy to share the slides. So like this came from SAMHSA, that top number. So they have a annual national survey on drug use and health that they conduct and update these numbers every year. And they do break it down depending on the report you're looking at for NSDUH by age group.
Okay, thank you so much.
I also have a follow-up question.
Yeah.
I remember briefly, maybe a couple of months ago, the University of Michigan released similar data on like substance use across the United States. Did you tap that data as well? Or is this
I did not. This is just an overview of national numbers. And generally, I go to the NSDUH survey because it's one of the most robust population specific surveys that are done. So it's ideally, it's set up to be representative of the US population, which is important when you're talking about prevalence. So, for example, if you used a survey from Michigan to say, this would have to say females in Michigan, this is their prevalence, versus using the NSDUH survey, you can say, this is the prevalence among females 12 and older in the United States.
interesting?
This is from the same survey, the NSDUH. So this survey is supported by SAMHSA. It's done annually. So this is illicit drug use among women. So this is also women aged 12, so females 12 and older. This is just how NSDUH groups it. I'm sure they break it down in other reports by age group. But so 1.5%. So just looking at like in comparison to other substances, of course, marijuana is the most prevalent. Therapeutic drugs, cocaine. Surprisingly, it falls right there within cocaine. I'm sure if you threw alcohol in this, alcohol would be the number one. But one thing about hallucinogen use, and so hallucinogen is how SAMHSA calls it instead of psychedelic, is it has been increasing over the past few years, much more than we've ever seen. So it is starting. So these numbers are important because they get funding. The eyes of the people who decide on funding proposals, they start to begin that conversation, because if the number is, I don't know, let's say 0.1% of people, nobody's going to fund you to do a study, honestly, depending on the study. But so you can't talk about psychedelics without talking about some risks. There's hallucinogen persisting perception disorder, total or partial recurrence of perceptual disturbances that appear during the experience and reemerge without use. It's rare with limited prevalence rates, i.e. not a lot of prevalence data being collected at the population level. It's more common following LSD or PCP versus like psilocybin. And then hallucinogen use disorder, meaning like compulsive use. Of course, it is rare, but it does happen. And so the risks of psychedelics vary by the type of psychedelic, the setting, so like where the person was, who they were with, the dose, of course, how large of a dose they took, and importantly, their history of psychiatric disorders. For example, psilocybin is not recommended, even in the therapeutic community. and religious community, among people with bipolar disorder and schizophrenia. So there are more risks for certain people using psychedelics. And there's actually societies now for and support groups for people that have had adverse experiences with psychedelics and people that had long-term years of effects. This is just looking at this is the number of shroom seizures in the US. So US population, 5 years-ish, 4 years, you've got sort of just this huge curve going up of the number of shroom seizures, just to give you an idea of the increase in use since 2017.
And what's a shroom seizure?
So this would be like when the cops take psilocybin mushrooms from somebody.
Yeah, that's very important to clarify.
Yeah, sorry. Actually, I never even thought about that title being, that was this paper's title. Yeah, so seizure as in the cops take somebody's drugs from them. So that was their figure title, but if you look down at the link, it says trends in seizures of shrooms. Seizures of shrooms. That's a bad figure title, but yeah. I've never heard of somebody having a seizure while taking shrooms. It is possible, I guess. Okay, so psilocybin, shrooms specifically, NSCUH, this is a 4-year number, 8% of lifetime use. We don't have any prevalence data on pregnant people for psilocybin use, but we know that from just the media push of psilocybin use among moms and organizations like Moms on Mushrooms, who are great people that I've partnered with for my survey, that psilocybin is being used by moms and women. So some perceived and potential benefits. So potential benefits would be reduction in maternal mortality. So in Florida, overdose is the #1 cause of maternal mortality. This is death within 1 year of giving birth. That is extremely alarming and that's been the case since 2017. Reducing postpartum depression, suicide, substance use disorders, trauma, PTSD, all things that adversely affect women and their children and their future offspring. And then some potential risks. So we have zero data on psychedelic use during pregnancy and what could happen. We know that psychedelics do cross the placenta to the baby. We also know that it's very likely that psychedelics are present in breast milk. We don't know how long they're present in breast milk. For example, there's plenty of research on marijuana and that can be present in breast milk for up to 2 or 3 weeks. Don't know how long psychedelics are present. Of course, there's the risk of DCF or law. DCF is the Department of Children and Families. So as a mom and a pregnant person, there's always a risk of being reported to the Department of Children and Families and having your child taken away when you're talking about a substance that is illegal, and law enforcement involvement. Hallucinogen use disorder seems to be pretty rare, but it's a thing. And then just physical safety, taking large doses of psychedelics around your children definitely has some potential for harm. And even for yourself, taking a large dose of psychedelics without a safety plan or being in a safe place can be very risky.
I have a quick question.
Yeah.
So you mentioned we don't know much about psychedelics and the use, for you said it crosses the placenta and the baby will be exposed to the substance. Have you guys considered looking at indigenous tribes? Because I'm not 200% sure, but I've heard that there's some tribes that they promote the use of psychedelics while they're pregnant, and you could potentially use it as observational data.
Potentially. I doubt that tribes would share data with you like that, or that they collect data like that. Some of them might. That would be a nice route to go for. It's not something I have experience with. I I have been told that some tribes use psychedelics during birth, like during the delivery experience, um, to help support the process. I've never heard of them using it like during pregnancy, like before delivery. But
Yeah, I could be right.
I have heard that it's more of like during delivery. And so that's not as much of a concern because, oh gosh, because the baby is actively on the way out. Versus when we think about placental transfer of substances, um, it's really like how much is building up in the placenta, how often somebody's taking a substance, and how much they're taking. So somebody taking psilocybin once during pregnancy versus somebody like microdosing every 3 days during pregnancy is a big difference in terms of like exposure for a fetus.
Right. Yeah, that makes sense. Like there is we did a observation. We reviewed a paper by this lady. She's from Venezuela, and she went to Peru, and she collected observational data on like this tribe in Peru. Forgot where it was, but they would take ayahuasca, and they allowed them to collect data. So it is possible.
That's cool. Yeah, that would be awesome.
I'm seeing a question in the chat here. Dr. Elmore, do we know if there's a correlation between SIDS and psychedelics?
There's no research, there's no data. No. I'd say the most common causes of SIDS is safe sleeping environments. On that note, no blankets in the crib, no bumpers on the crib. If people decide to co-sleep, you have to be very careful.
Understanding the placenta breaking through that and being able to go to the child, is that known through like rat studies, or like how do we know that the transfer is possible?
Yep, through a rat study, and it actually was one that it was like from the 70s that I found. So there's not even been recent animal research on psychedelics and like pregnant pups, for example. It was an abstract I found from the 70s on that it crossed the placenta.
There's so much room for research. It's crazy.
There is very much. Yeah, and honestly, animal studies is really where it needs to be happening too, because there's only so much research you can do with pregnant people. We're about to talk about a couple studies that you can do with pregnant people, but obviously you can't like give them a substance and then follow them and see how their infant turns out.
Right.
I have a question.
Yeah.
So you mentioned that it could be dangerous for like the baby through the placenta to take in psychedelics, but you said it wouldn't be as much of a problem when they were giving birth. But then if it stays in the breast milk for 2 weeks, is there still some sort of danger to that?
So we don't know how long it stays in the breast milk. It would depend. The 2 weeks that I said was for marijuana, and marijuana can actually stay in the breast milk for up to a month. But yeah, there's no current data right now on, and you'd have to look at the specific psychedelics, right? So like, how long does psilocybin stay in breast milk? We don't know. How long does LSD stay in breast milk? We don't know. My presumption is that it's probably shorter than marijuana. But we don't know.
Oh, okay. Thank you.
If I might add, we do know about ketamine. So ketamine actually stays in breast milk it's got a half-life of about 3 hours. So women can safely do a treatment of ketamine and breastfeed it's something like 3 hours after their ketamine infusion. So that is one we do know about. There's no research on ketamine during pregnancy, but during breastfeeding, ketamine is okay as long as they wait.
Oh, okay.
The
Thank
chat
you.
that is interesting.
Good to know.
Oh, wait, they said the half-life is 3 hours.
Remembering off the top of my head, yes. Or not the half-life, the whole life. From the study that I read, if you want, I can try and find it and send it in the chat. I believe it was 3 hours after that it's safe to breastfeed.
And ketamine is one of those that's probably has some of the most data since it is Schedule 3 drug now. So it's actually accessible. Versus Schedule 1 drugs are much more difficult to research. Okay, so when thinking about this sort of on a schematic and maternal mental health, so all of these things affect a pregnant person and affect their offspring and themselves. So the question is sort of like, where do psychedelics and psilocybin fit in? Do they help and stop these things, or do they potentially cause other harms? We don't know. Okay, so we have 3 current studies that we're going to talk about. First, Marina's going to talk about the association of, that should say, psychedelic use among women of reproductive age and substance use disorders. My apologies. The first time we did this, it was just psilocybin and opioid use disorder. Then I'm going to talk about a survey on psilocybin use during or after pregnancy that's ongoing, and then mention the post-trial participant study of psilocybin and postpartum depression. Okay, so I'm going to hand it over to you, Marina.
Okay. Yes. So where Giovanni and I met at the conference, our Dr. Elmore and I's research focused on only psilocybin and opioid use disorder. This research is an expansion of that research, and we're going to look at multiple psychedelics and multiple substance use disorders in this research. Next slide, please. So the objective of our study was to determine if lifetime use of classic psychedelics was associated with the prevalence of recent substance use disorders in women of reproductive age. So let's just break that down a little bit. Lifetime use we define as once or more during an individual's life course. So in our study, we're looking at people who have used psychedelics once, and people who have used it many, many times. It's all the same for the purposes of this analysis. Classic psychedelics we define as psilocybin, LSD, DMT, AMT-foxy, peyote, and mescaline. Those have a similar mechanism of action, and so you'll notice ketamine and MDMA are not included in this because they have a different mechanism of action. Women of reproductive age we define as females aged 18 to 44. The gender variable, sex variable, was a binary, man or woman. So that is what we define as female, somebody who checked off the woman option of the survey. And recent, we define as within the past 12 months for the substance use disorder. Next slide, please. So I've already gone through this a bit, but just to reiterate, substance use disorders are associated with adverse maternal and child health outcomes. Previous studies have suggested that psychedelic drugs may be associated with a lower odds of a substance use disorder. And resulting from those studies, clinical trials have been popping up that are using psychedelics to treat substance use disorders. However, that being said, research on this association between psychedelics and substance use disorders is extremely limited on women of reproductive age. It's hard to find stuff that's stratified by sex alone, but it's nearly impossible to find anything that is stratified by this population of women aged 18 to 44. Next slide, please. So we mentioned previously the National Survey on Drug Use and Health. And again, that's a SAMHSA data set, federally collected and publicly available. So we used the years of 2015 to 2019. And we picked these years for a few reasons, but one of those reasons was that this was before psychedelic use became very prominent clinically. So we can safely assume that people using psychedelics between 2015 and 2019 are mostly using it recreationally, like in a naturalistic fashion. So it's part of the reason why we chose this. Our sample size is about 80,000. We use SAS 9.4, proc survey procedures used for complex weights and strata. For our models, we use survey logistic regression with hierarchical model adjustment to account for confounding variables based on some DAGs, directed acyclic graphs. Next slide, thanks. So this is our, they call it a DAG for our fourth model, which is adjusted for the most variables. So here, as you can see, we've adjusted for different demographic variables such as age, race, education, mental health variables, past year and lifetime depression, risk taking, and also the use of other drugs. So this is an epidemiological tool that we use in order to kind of figure out what variables should we adjust for. So if you follow the lines of the arrows here, you can see that, for example, lifetime psychedelic use affects, risk-taking affects lifetime psychedelic use. So we would adjust for that in our model. Next slide, please. So our independent variable is our psychedelics, which is measured in the NSDUH by the question, have you ever, even once, used substance? So again, psilocybin, LSD, DMT, mescaline, and peyote were what we measured. And for the purposes of this analysis, we made a composite variable of the above. So this is basically anybody who has used psilocybin or LSD or DMT or mescaline. This is not somebody who has used all of these drugs. This is everyone who has used at least one of these drugs. Next slide, please. And for our dependent variable, we have our substance use disorders. So these are recoded variables based on the, there should be DSM-5 criteria of clinical substance abuse and dependence within the past 12 months. I believe there's about 11 criteria, and this variable was recoded within the NSDUH to represent abuse or dependence, which we simplify in just talking about it as a substance use disorder. And we looked at alcohol use disorder, marijuana use disorder, opioid use disorder, and stimulant use disorder. And similar to psychedelics, for the purposes of our analysis, we also created a composite variable looking at just alcohol, marijuana, opioid, and stimulant use disorder. Next slide, please. So let's take a look at our models. Our first model is a crude model. So we're looking only at psychedelics and substance use disorders without controlling for any other factors. Our second model, we're controlling for demographic variables. Again, age, race, marital status, income, all that jazz. Our third model, we adjust or control for all of the Model 2 variables and also lifetime depression, meaning a depressive episode in someone's life at least once, past year depression, meaning a depressive episode in the past year, and self-reported likelihood of risk-taking behavior is our last variable in the third model. For our fourth model, we include all variables in the second model and third model, and also polysubstance use, so use of other drugs. And we'll get into this more in a moment, but that's looking at marijuana, cocaine, tranquilizers, sedatives, everything you could possibly imagine we adjusted for in this other drug variable. Next slide, please. So what did we find? To give a little bit of context to the results, I'll just go through some of the descriptives. About 8.1% of women in the sample reported an alcohol use disorder, marijuana use disorder, opioid use disorder, or stimulant disorder in the past year. Next slide, please. Of those 8.1% of women, that's about roughly 7,000 women. Of those, most of them had alcohol use disorder, followed by marijuana use disorder, followed by opioid and stimulant use disorder at a bit of a lower level. Next slide, please. I'm not going to go through all of the demographics for the sake of time, but a couple of notable ones are the racial distribution of the sample and the education distribution of the sample. As Dr. Elmore stated previously, this is intended to be a representative sample of the United States. Most of the sample is white, followed by Hispanic, Black, and then Asian, American Indian, Alaska Native, Pacific Islander. So most of the sample is white, and most of the sample has at least some college education. So I think that's important to contextualize this research. Next slide, please. So again, moving from our psilocybin study to our psychedelic study, there's a couple of leftover artifacts of words. So this should say used psychedelics, not used psilocybin. That's my error on my part. So of the population who has had either either a alcohol, marijuana, opioid, or stimulant use disorder, 23.3% of those people have used one of those psychedelics that we mentioned previously or more. Compare that to the entire sample, where only 11.3% of the entire sample has used any kind of psychedelic. So as we can see, people who use drugs are more likely to also use psychedelics. Next slide, please. Okay, I know this is a lot on this slide, but we'll break it down step by step. We'll go through it. So if I could direct your attention towards model 1, as you can, oh yes, if we could do a little pointer, that would be awesome. Yes, so model 1, if you take a look at these numbers here, they're pretty high. So we've got substance use disorder, alcohol, marijuana, opioid use, and stimulant use disorder. Particularly stimulant use disorder is a very high odds ratio. And basically what this means, because the odds ratio is positive and above 1, this means that women who have used a psychedelic are more likely to have had an opioid or a substance use disorder in the past year. And by a lot in this crude model. And again, this is looking only at psychedelics and only at substance use disorders without considering any other factors. So we move to model 2. Model 2 adjusts for those demographic factors that we talked about, taking out of the equation age, education, income, and we can see some slight increases and decreases here. Not too much change, but in model 3, which adjusts for these demographic factors and depression and risk-taking behavior, we start to see some reductions in these numbers. So that means that depression and risk-taking are having an effect on the relationship between psychedelics and substance use disorders. So that brings us to model 4, where we get the lowest numbers out of all the models. That being said, if we take a look at model 4 with past year substance use disorder, that first one up top, that basically means that if a woman has used a psychedelic drug, she has double the odds of having a substance use disorder in the past year, which is really different from everything else that's out there. And we find it pretty concerning. So the lowest odds ratio there is 1.7, which is still considerable. And the highest one there is 4 for stimulant use disorder. And I'll go down to the last thing at the bottom there. We controlled for marijuana, cocaine, PCP, stimulants, tranquilizers, sedatives, pain relievers, heroin, MDMA, and inhalants. So that's the complete list of everything we controlled for in terms of polysubstance use.
I'm sorry, I'm so ignorant. So when you say you controlled for it, what does that mean in terms of like the study? Like if it's being controlled, does that mean you put that aside and we're not looking at those who did that, or you adjusted the models in some way? I just don't understand. Maybe you could just make it a little bit clearer for me.
Dr. Elmore, do you mind if I pass that off to you? I think you'll be able to explain better than me. I think you're on mute.
I am on mute. Okay, so essentially, like model 1, we're calling our crude, which means like, so we're looking at 80,000 people and using statistical methods to look at the association between psychedelics and substance use disorders. And my phone's ringing. So this crude model, all we're putting in there is psychedelic use and substance use disorder, like X equals Y. X
Right.
points to Y. But we know that there's a lot of other variables that affect the association between psychedelic use and substance use disorders, such as age, race, ethnicity, pregnancy, meaning that depending on these variables, somebody is more or less likely to use a psychedelic and to have a substance use disorder. So when we say we adjusted, it means you're adding these variables. You can sort of see like plus adding all these variables, adding those to the model so that they aren't impacting the association that we're wanting to look at, which is psychedelics and substance use disorders. So ideally, in our most adjusted model, adjusted odds ratio, AOR, we adjusted for all variables that we had at our disposal in this data set that would affect the association between the two, to say that this is the best number we could come up with, that took all these other things out of the picture. So depression could no longer cause the odds ratio to be higher. Other substance use is a big one. So obviously, if somebody is using another substance other than a psychedelic, it's going to increase their risk for a substance use disorder. And so that's how we end up with our final odds ratios. But as Marina mentioned, they're all still over 1, which means that psychedelic use was still associated with an increased risk of a substance use disorder. If these numbers were under 1, like 0.7 instead of 1.7, then we would be saying that psychedelic was associated with a lower risk of a substance use disorder.
I see. Thank you so
So
much. That makes it more clear for me. Yeah.
Definitely.
awesome.
Thank you so much. Yeah.
Yeah, thanks, Dr. Elmore, for clearing that up. So that means there's something like the psychedelicness of the psychedelics, if that makes sense. Like there's something inherent to the psychedelics that is having this association, as opposed to something else causing it or getting in the way, if that makes sense. So yeah, I think
I would be interested if you guys would do this again with updated data, obviously. As you mentioned, you use this sample size or the population that was prior to clinical trials. I wonder if those numbers would change now that people are using it more consciously.
yeah, that would be really interesting information to look at. Because actually, Dr. Elmore is going to talk about one of her studies in a moment, which looks at intention of like it's a survey which looks at somebody's intention when they take psychedelics. Is it for personal growth? Is it for like a spirituality situation? Or is it purely recreational? Is it to escape? So that is definitely something very interesting that I agree we should look at.
Have you also looked at dosage? Because at a lower dosage, for example, psilocybin, there's different purposes, right? So it's like the association of people who take lower dosages versus higher dosages. Did you account for like the amount of psychedelic use?
So unfortunately, we are limited by the parameters of this data set, by the parameters of the survey. So they did not collect information on, let's say, a microdose versus a macrodose of psychedelics. So we have no information on that. But again, the same study, Dr. Elmore is looking at the differences between microdosing and macrodosing in women. The study that she's partnering with that organization, Moms on Mushrooms, with. So Dr. Elmore will speak to that in just a moment. But I think I'm ready for the next slide. So long story short, women who have used classic psychedelics have a higher odds of a past year substance use disorder compared to women who have not used classic psychedelics. And these findings are discordant with almost everything else that's out there. The only difference between our research and this other research that's being done is that we're looking only at women of reproductive age. So we hope that the takeaways from this are that we should stratify this research, right? Well, yeah, in the sake of time, I'll skip over the anecdote I was going to go over. But yeah, so we feel like this research should be a springboard. This is a preliminary analysis. It has not been peer reviewed, so take that as you will. But we think that this research should be a springboard for future research, and even going back to past research and seeing if we can stratify out by this population of women of reproductive age, because bodies that menstruate are different from bodies that do not menstruate. So it's very important to look at these different bodies that are physiologically different, because we don't know how substances will affect them differently. And I believe that's all I have. So I'll pass it off back to Dr. Elmore.
Did you have a hypothesis coming into this? I'm sorry to interrupt you, Elmore. I just was curious if you had, when you were going into this research, it seems like we all would have expected the complete opposite, but did you have kind of a premonition that maybe something's off here?
Yeah, I think our hypothesis is definitely, oh, it's going to be great for women. We were kind of expecting, the complete opposite. You're exactly right. So we were quite surprised by this when we saw the analysis.
And we based it off of a previous study we tried to essentially do the same thing, but their results were among men and women, and they found a lower odds of substance use disorder in their study versus we found a higher odds. And the only difference is that it was our sample that we restricted just to women of reproductive age.
Yeah, they used the exact same sample as we did, but they found a different result.
And were the men and the women sample size equivalent, roughly? Or was it like significantly more men in that sample or something?
Yes, so just to clarify, that other study had men
Yeah.
and women, everybody together of all ages.
Yeah.
And we looked only at women of reproductive age.
Right.
So they found a decrease with everyone, and we found an increase looking only at this subset of women of reproductive age. If that
Yeah.
makes sense a little more
It
clear.
makes total sense. I was just curious, in that other sample where they found the decrease, was the men and the women sample size about equal?
Yes.
Oh, wow. That's insane.
Yes.
Okay, so I'm gonna jump to the next part and try to hold questions to the end, or else we might not get through this.
Thanks. Sorry about interrupting.
No, it's totally cool with me. It's just we have like 7 minutes left, and people might have to go somewhere. I will say the other limitation of NSDUH that somebody mentioned was, oh gosh, now I lost it. Intention was, sorry, I have like my construction people calling me. Intention was one. So like why they decided to use it, we don't know in this data set. Now I don't remember the other one. It'll come back to me.
Micro and micro, like the dosage.
That one, yes. We don't know the dosage. Yeah. So they didn't ask dose. It's just a yes or no. Have you used this substance? Which is a big difference. Okay, so I'm going to talk about psilocybin use among pregnant, postpartum, and parenting moms. So I developed this survey to supplement clinical studies that are showing benefits of psilocybin mushroom use, but pregnant people cannot be in trials, and most often postpartum, meaning like 1 year after delivery or birth, people are not usually in trials, and it's actually kind of hard to get women of reproductive age in clinical trials because they usually require you to be on a hormonal contraceptive during a clinical trial, which not all women want to do. So this is the flyer. Okay, I'm gonna just one.
Wow.
So this is the flyer. I will pick up for Dr. Elmore. My good friend and colleague designed this. I think it looks great, but
I love it.
Okay. Sorry, there's people tiling my bathroom and asking how, like, what direction I want it to be done. So sorry. Okay, so this was the flyer for the survey. This was a study team made up of 3 different universities, actually. This is the importance of going to conferences and networking, which I think this presentation itself is a nice example of that. But so I have my people from the University of South Florida, some collaborators from the University of Iowa, Department of Epidemiology, and then the Ohio State University Center for Psychedelic Drug Research and Education. One name that might stand out to you is Alan Davis. His name is all over psychedelic research. So the aims were to describe the sociodemographic, so the WHO, and clinical characteristics of moms that report psilocybin use. 2, understanding the amount, so micro versus macro, the frequency, the intention, and the setting of psilocybin use among moms. And then 3, to look at some associations between most recent psilocybin use and changes in health and behavior, perceived benefits and risks, and parenting experiences of moms. And so this survey was sort of like a step 1 to getting some research going on moms and psilocybin. So the sample was pregnant, postpartum, and parenting moms that have used psilocybin during or after pregnancy. And for the inclusion criteria, have you ever been pregnant? They could have become a mother through other routes, such as adoption, marriage, or surrogacy. So it wasn't restricted just to women who carried a child. Inclusion, we didn't have the funding to do anything other than English, 18 years or older for IRB purposes, history of pregnancy and motherhood, and then psilocybin use during or after. And this after pregnancy, there was no time limit, so it could have been 10 years after they were pregnant. So we disseminated it through a targeted recruitment method, and snowball just means that we said at the end of the survey, if you know any other moms that might be interested in this, please share. And so the main groups that shared it that we got responses from were Moms on Mushrooms Incorporated. I posted on their like internal member board, Sanctuary Church, isn't on this graphic, but I know there was a couple that people that completed it from there. That's a church out of Kentucky that uses psilocybin as a sacrament. Tricycle Day is a great, I don't know what they're called. They have like a new e-newsletter that comes
Yeah,
out.
newsletter. Yeah.
Yeah,
I'm
they had
subscribed.
it's great. So we actually got a decent amount of responses through Tricycle Day. And then there was a Moms on Mushrooms Facebook page that was like not the same as the other organization, but I didn't get very many responses from that, surprisingly. But so we gave a $100 gift card to every 25th survey participant, and we collected their email address to give them the gift card on a separate form so that their responses were anonymous. So this was done through RedCap. I'm going to go through some of this quickly so you can actually see some results. And we did a pilot of the survey, meaning we tested it out with other moms to see how it worked, and they got a gift card for doing it. Okay, so far, since August, we've had 95 people complete the eligibility criteria, 71 made it past the informed consent page, 64 completed the informed consent in some of the survey, and we have 50 completed surveys where the person answered all of the questions. I'm not going to spend a long time on sample characteristics, but just pointing some out. And so the next few slides, I'm sorry, are not that pretty, but they're essentially tables of microdoser versus large doser. So out of the 50 people, 34 reported microdosing versus 15 reported taking a large dose of psilocybin. So a majority of our participants reported microdosing, which makes sense because Moms on Mushrooms is a microdosing community. Majority white, highly educated, and mostly married or divorced. Household income's pretty high. Employment status, most people were employed full-time or part-time, and had private insurance. This was reporting of other psychedelic use. So to get into the survey, they had to have used psilocybin before. This was the other psychedelics that they had used before. So LSD being the most common, and then ketamine being the second most common other psychedelic. And frequency of use, as we know, microdosing is every 3 days-ish, depending on what regimen you follow. So a lot of people did not answer this question, probably because they don't know. If somebody does it every 3 days, that would be hard to count. So a wide range of like how often somebody used it. Okay, so intention, so interesting things. So this was, it asked what their most recent psychedelic use, most recent psilocybin use was, what their intention was. And you can see that nobody said that they had no serious intention for their most recent use. Some of the major ones were psychological self-exploration to cope with parenting, which is really insightful. Mental health, exploring spirituality were the main ones for intention. We do have recreational, 5 people microdosing, 4 people large dose, but that was certainly not the most common response. And then did you talk to somebody about your experience, which is what the psychedelic world likes to call integration. And so about 30%-ish of microdosers said no, which is a different experience. Most people talk to a close family or friend. 32% said a therapist or clinician among the microdosers, and then 27% among large dosers. Okay, so changes in substance use disorders, or substance use, not disorders. 61% said they reduced their alcohol use among the microdosers, 27% among the large dosers. And then change in substance use overall was a little bit lower. About 82% said no change. And then all of the large dosers said no change in terms of drug substance use, aside from alcohol and tobacco, which that could have meant that they didn't use other substances, of course. Changes in mental health. So 97% of microdosers, 86% of large dosers said yes, they had a positive change in mental health. The most common reported was reduced in depression symptoms, reduced anxiety, and improved overall mental health, with most people reporting about 1 to 2 to 6 months of the time that it lasted. We did have some people say they had negative changes in mental health, so to not be biased, we asked about both. 6% of microdosers, 13% of large dosers said they had a negative change, increased anxiety, decreased overall, increased depression. And then lastly, so changes in parenting. So we're still looking at this data. We have some free text fields or qualitative data that we're looking at of what they actually said changed in their parenting. But so 76% of microdosers said they had a positive change, 53% of large dosers. And preliminarily, a lot of the people reported that they had more patience and were able to be more present with their children. We didn't get a lot of people saying that they had breastfed while using psilocybin. There's been some reports of menstruation changes following psychedelic use. I think that's mostly large doses, so about 13% said yes. And then we asked about parenting duties. So who's in charge of your children when you use a psychedelic substance? Of course, microdosers, most people said myself, because it's supposed to be sub-perceptual. But a co-parent, babysitter. And I think it's 4 o'clock, so I'm not going to spend a lot of time. This is just this is beginning in the spring. So there's a trial at USF for psilocybin and postpartum depression. I reached out to that team in the College of Medicine, and I'm going to be doing follow-up interviews with the people that did that trial to ask how they thought it helped or did not help their postpartum depression, their experience with psilocybin as a trial and during postpartum, because there's just not a lot of trials that we conduct during the postpartum period and not a ton of trials on psilocybin among that population. So that's currently under IRB review and planning to do interviews in the spring. So overall, women-centered psychedelic research is needed to identify reproductive risks, but also tailor psychedelic therapy to improve maternal health outcomes. Questions?
Yes, thank you so much for that. Very insightful. I'm gonna go ahead and actually I'm gonna keep the recording going. But yeah, if anybody needs to leave, you're welcome to leave. But I do have some questions. I'll start off with one question that comes to mind. There's two, so I'll start off with the first one. I during the conference ICPR where I met Marina, uh, I had the sense where a lot of people were saying, and I looked at the studies as well, that microdosing doesn't really work. And here we are, you have a study with mostly moms saying it did help me. I just want your thoughts on that.
I think it's an area that's under researched, and I think it really depends on how you're collecting that data. So, I mean, there's not very many, I don't actually know. There's no trials on microdosing for multiple reasons, but mostly all of the hoops to jump through to do a clinical trial. So I think it's just an area that's under researched, and the data you get is only as good as how well you collect it and the way that you ask the questions. So
Right, yeah. That makes sense. It just
and it depends
yeah.
on who you're asking. So a lot of our population was from Moms on Mushrooms. So those moms went and looked for that organization, joined it, had a purpose for joining it, had an intention before they even started taking psilocybin. And so that does,
That
affect the
definitely plays a
results.
factor, 100%.
Yes.
And another thing is, and I didn't know this actually blew my mind. You said, just for clarification, you said postpartum, like after they give birth, the number one cause of death was some type of substance use, overdose.
Overdose in Florida. Yep.
Wow. Wait, so that's just in Florida. And what about, do you know
In
if
many
there's,
other states too. Yes, in many other states.
wow, that's actually
Florida's actually
crazy.
not even the leader in it.
Wow. That's insane. Okay. That's
Mhm.
my questions.
Is there a big do you know if there's a main reason for why that is?
Um, well, substance use is very common, despite what people want to believe. And pregnancy does not treat a substance use disorder, is what I like to say. Like, just becoming pregnant doesn't like fix a substance use disorder that you have. Um, and getting treatment that is non-stigmatizing and accessible in terms of money and transportation and location and also good treatment is really hard when you're pregnant. Most people are extremely judgmental, even clinicians. And so a lot of people don't get treatment while they're pregnant. Even if they do, it's sometimes suboptimal. And then, so most of these deaths are occurring in the postpartum, not while the person's pregnant. And a lot of that is also making sure that they have continued access to treatment. So and they're usually in the later postpartum. So like 3 months to 1 year after giving birth is when most of them happen. So they've gone to their 6 week postpartum visit, maybe, and no one's checking up on them anymore at that point. They now have a stress of a 3-month-old, of course. And so sometimes people stop taking their treatment for substance use disorder. And most of these, probably 90% or more, involve opioids, which is just a difficult substance use disorder to treat long term.
And trying to combine the two studies of psychedelics seeming to have a strong correlation with substance use disorders and the fact that the study that you did recently, well, me still doing, right? That microdosing and even macrodosing helps mothers become better parents. It helps with postpartum depression. So combining this kind of like, or trying to come up with a consensus, do you recommend um, certain psychedelics for not during pregnancy, but just after?
I
Recommend psychedelics. I would say,
Or like just to be like just to just to by
yeah,
recommend
it's a great
like
question. It is a great question, and one that I'm going to try to give you a political response to. Um, my
love.
thoughts are: number one, if somebody has a severe mental health condition, maybe not, because especially bipolar disorder and schizophrenia, or even if you have an immediate family member that has one of those conditions, I would not recommend it ever. Because it can push somebody into mania or cause one of those conditions to then develop, even if somebody wasn't diagnosed with it before. So bad things can happen, essentially, if you have a history of mental health conditions. My other safety check would be where you're getting the substances. Like, okay, psilocybin's a little bit somewhat safer because it should look like a mushroom. But the illegal drug market, which is where anyone that's not in Colorado or Oregon would be getting psilocybin, can have all kinds of things in it. That's number two. Number three would be there's safe ways to use psilocybin and there's unsafe ways to use psilocybin. So if somebody was interested in taking them, say, to replace an antidepressant, which is why a lot of these moms do. So they don't want to be on an SSRI anymore. They want to be able to microdose instead of that. You've got to talk to some sort of doctor. It might have to be a telehealth appointment with somebody in Colorado. But either way, I would reach out to some sort of clinician to get their advice on it before. But in general, psilocybin is safer than other drugs, other illicit substances.
Yeah, that's what I'm saying, because LSD compared to psilocybin has higher chances of developing the persisting disorder, the and that's kind of actually what I've been thinking about, because if we tried to classify all psychedelics as the same, it's like they're really not, you know. I feel like if we create those distinctions, that might like promulgate or not promulgate, progress research because the population will have a clear understanding that not all psychedelics are created equal, you know?
Absolutely. And that's going to be the next step of our research. I showed you that table that had the substance use disorders, and then we used the composite variable. Next step is to do each individual psychedelic with each individual substance use disorder. However, that would be an extremely large table. So for the purposes of this presentation, we just use composite psychedelic. But I totally agree. Yeah, they should be viewed as separate substances.
Yes, and it's important to like. There's a lot of variables, and most people talk about set and setting. So set, like, what is your intention? What are you expecting to get out of the experience? And setting where you are, who you're with, who you're talking about with it after. A lot of research is showing that, like psilocybin, for example, use without integration afterwards. So without like talking through the experience and what it was, especially large doses, doesn't have as many benefits as if you versus if you didn't talk to anybody like through the experience. So when we're looking at data on a population level, it's really difficult. If you can get data on more of like a clinic level, like a clinic in Denver, where you have all of this information, that would be the best gold standard to be able to give some solid results.
Hi. I just wanted to say that I think the study is really amazing, how you guys have focused on women and like seeing how women bodies are different from men's bodies, which I think a lot of researchers don't take into consideration. And I think that we should start looking more into that. So thank you for your research and everything. And I just wanted to ask, like, do you think that studies like with psychedelics have more issues gaining like sponsors or funding that compared to other research?
I think they get different funders. So there's a lot of private companies now that are getting into the psychedelic arena because it's a new hot drug that's making them a lot of money. And so the psilocybin postpartum depression trial I mentioned is sponsored, like a private company funded, and the post trial is also a private company funded. Versus a lot of research is supported by like the NIH, National Institutes of Health. Although the National Institute of Drug Abuse, or NIDA, also supports psychedelic research, not a ton, but they do. So any research, it's about finding those funding streams, but there is a lot of private sponsors now for psychedelic research.
Okay, thank you.
A lot of it, though, is everyone's focused on clinical trials because new drugs make people money, and you have to do clinical trials to get new drugs on the market. So that's certainly where a lot of the money is going.
Okay, thank you so much.
Mm-hmm.
I have a question. So I asked this kind of similarly to like another guy that came in, but I was wondering because I noticed that like people said that they were having a positive correlation or a negative correlation depending on where they were in the month. And I was wondering if your study had accounted for like where they were in their menstrual cycle.
I did not ask that in the survey. That would have been a good question, but that it is something that has been sort of building in my mind. Just anecdotally, I've heard that certain phases are when you should dose. Marina, if you happen to remember what that woman said when we were at ICPR, some clinics, like ketamine clinics, and there's not very many psilocybin clinics at this point, but they do recommend dosing during certain times of the month for that exact reason, which makes sense because hormones, go up and down so drastically depending on where a person who can become pregnant is in their cycle. So it's definitely important. I actually had a researcher from California, reach out who's trying to push that in all clinical trials to have any clinical trial with a person who can become pregnant, or woman, or birthing person, what term you want to use, to start collecting what phase they are in their cycle in the clinical trials, because it's an easy data point. Yeah, it's an easy data point to collect while you're collecting everything else, but it's extremely impactful for women's health.
And it could cause a lot of like variance in like what people are saying is different for them. And it could be completely because like, oh, I'm menstruating or oh, I'm ovulating right now, as to
Right.
why like that's different.
Yep.
Yeah.
Very true.
To add to that, because right now I'm learning a lot about the extraneous variables, and I'm so unsure as to why like a woman's cycle wouldn't be considered an extraneous variable because it's always changing,
Mhm.
you know.
It should be considered a variable. It's not something that's available in that large data set that we used. And my survey wasn't really looking at specific, like, it's more of a step one, but I definitely think that it should be something that's collected in the future. Also, I think it's a little bit hard when you're talking about microdosing because, again, at least moms on mushrooms, their regimen is every 3 days. So when we're thinking about like where in the menstrual cycle it falls, you're really talking about large dose experiences, or like infrequent use, right? Because if you're doing it every 3 days, then that would be hard to pinpoint.
That makes sense. Yeah.
Thank you so much for having
Yes.
us.
Yes, thank you.
Thank you
Thank you
so much for
for
coming. Yes. Thank you.
Thank
Uh,
you.